delighted to welcome you all to our very first session of the National Road Safety Webinar Series, which is brought to you by Crashfree India. Crashfree India is a CAST24 commitment envisioned to build safer roads by turning awareness into action. We're a growing community of change makers who believes that road safety isn't just a government responsibility, but a public movement that should involve everyone, which is why we're glad to see so many participants. And what better way to kick off this series than by focusing on one of the most recent and transformative interventions, the Cashless Treatment of Road Accidents Victims Scheme 2025. This was launched recently, and this scheme allows any road accident victim to receive immediate treatment at a designated hospital for an amount of up to 1.5 lakh rupees for a maximum period of 7 days from the date of such accident. This policy addresses the most crucial aspect of crash. To explore this in depth from both a clinical and policy perspective, we are joined by two distinguished speakers who have not just studied the system but shaped it. Let me begin by reintroducing our speakers, Dr. Sushma Sagar. First, it is my privilege to introduce Dr. Sushma Sagar, the professor and head of the AIIMS JPN Apex Trauma Center, AIIMS New Delhi. The Division of Trauma Surgery and Critical Care at JPN Apex Trauma Center, AIIMS New Delhi. Dr. Sagar is an expert in trauma care and critical emergency medicine with extensive experience managing patients who have suffered injuries from road crashes. Her clinical expertise and leadership has played and continues to play a pivotal role in advancing trauma care protocols and improving patient outcomes during the golden hour. She is actively involved in research and policy development to strengthen trauma systems in India. Our second speaker is Mr. Gautam Singh, Associate Director, Policy and Research at Save Life Foundation. Mr. Singh has played an integral role in policy advocacy and research to improve road safety and emergency response frameworks across India. Through his work, he has contributed to legal reforms and awareness campaigns that empower communities and promote timely assistance to road accident victims. His expertise bridges policy with practical implementations that support schemes such as this one. Together, they represent the synergy amongst healthcare, public action, policy, and practice. So without further ado, I'd like to begin by asking Dr. Sushma Sagar, based on your experience in trauma surgery and emergency care, what are the most critical clinical challenges faced during the golden hour post-accident that this scheme seeks to mitigate?
Thank you, Astha. Thank you for inviting me. And first of all, I would like to thank Crashfree India for taking this initiative, and seeing you youngsters working so hard for this initiative is really very heartening. And I'm happy that many participants have joined from all over the country. Believe me, this is a very, very critical aspect of saving life. And if we see the scenario in the global perspective, what we see that the people are dying because of cancer, and people are dying of diabetes and hypertension. But these are certain diseases, which are not preventable. And if you see people dying because of road accidents, it is very painful, because, this is one disease which is preventable completely. And in our trauma team, people call it as a silent genocide. It is killing people every day silently, and we are not aware. So it is a very big challenge, and if you allow me, I can share a few of my slides to engage the participants and to make them understand that how critical this scenario is. Are you able to see the slide?
Yes, we can see them.
Okay.
It's saying has started screen sharing. Maybe we can give it a moment. Yes.
Yeah. So if you see that, the problem in our country is that it is the single road and everybody is using it. But what I want to emphasize here, because we have more of the young people who are attending today, that it is the bikers and the two-wheelers and the pedestrians who are the major sufferers, and they are the most vulnerable people. And it is if you follow the traffic rules, if you wear the helmet, if you strap your helmet belt and strap it properly, and ask your pedestrian also to wear the seat belt and wear the helmet, then many of such type of deaths can be avoided. When the recent Ahmedabad crash occurred, it became a hue and cry, and everybody was talking about it. Until date, everybody is talking about it, that we have lost so many people in a single crash. But if you see the statistics, you will realize that more than the same number, the people are dying on our roads. Every 10 minutes, we are losing a life on our roads. The problem with our road is, which we have to understand, is that there are multiplicity of road users. You will have a cycle rickshaw, you will have a person going on a bullock cart, and you are having people traveling in a Mercedes, a very high speed car, and a truck and a tempo, everything going on the same road. So you don't have those kind of divisions. So what is required is that we need to change our behavior. We need to understand that if we are not aware of the road rules, if we're not aware of the road hygiene, then we will continue to lose our life. Remember, India lives in two centuries. On one side, you will find that people are just being carried away like this to the hospital, since we don't have a dedicated hospital services. But the picture is not so gloomy. On the other side, you will realize that we have very good pre-hospital care system in certain places, like you have in Hyderabad, in Chennai, in some parts of Delhi. In Rishikesh, you will find that you have even heli ambulances, wherein the people are shifted from the terrains, from the difficult areas to the hospital via air ambulance. So there's a huge gap. This is a valley of death. We need to realize that there's a huge gap between the policy and the practice. And I think it is the Crashfree India team from whom I hope that they can narrow down this gap by bringing in the like-minded people and to take care of that. So I would like to stop here, and then we can further say. So challenge is very high. Problem is that we are losing the young reproductive life at our hospital, where we receive 70,000 people per year. Almost 250 people are received every day by the various kind of injuries. And majority of these people are between the age group of 15 to 45 years.
So glad to see that wonderful presentation. I hope people got more of an in-depth understanding of the situation of road safety in our country. Um, yeah. So, Dr. Sushma, can you tell everybody a little bit more about the cashless treatment scheme overall?
So if we talk about the schemes, when the government realized that there is a huge gap between the between this people not reaching to the hospital, people lying on the roads, people bleeding on the roads, and people there's no one who's coming forward. So first of all came to begin with came the this Good Samaritan law. And I think most of the people nowadays know that what this Good Samaritan law is. It came in 2016, and we have Dr. Gautam here, Mr. Gautam here. It is the Save Life Foundation which had registered this PIL, and in response to that, this Good Samaritan law came into action, which says that if any person sees any accident victim and brings him to the hospital, then he needs to be appreciated, he needs to be recognized. Rather, what is the in the mind of the people is कि अगर हम अस्पताल लेके जाएंगे तो हमारे पे पुलिस केस हो जाएगा, हमसे सवाल पूछे जाएंगे कि आपको ये कहाँ मिला, कैसे लाए, खून कैसे बहा, किसने टक्कर मारी. So all these things are not asked. You are equally respected for hiding your identity, and if you want to reveal your identity, then you are appreciated, you are recognized. And like in our hospital, every night and every day, those who bring in these patients found unattended or who require any kind of help are brought to the hospital, and they are given this kind of a certificate, and their data is uploaded on the website. They are also given, if they are willing to accept, they are also given a 2,000 cash for this kind of support which they give to the accident victims. And similar kind of facilities exist in various part of the country. This was another thing which was added, and Rahavir policy by the Ministry of Road Transport and Highways, which says that if you save an accident victim, then you will be in the golden hour. Remember, for India, the golden hour doesn't mean that the victim has to be brought to the hospital within 1 hour, because we understand that the traffic, the roads, the terrains, we have some areas which are have easily access to the hospitals. So even if you make the patient reach to the nearest hospital or nearest facility up to 6 hours or 8 hours, that is also acceptable. And if you make that person reach to the hospital, to the nearby hospital in the need of the hour, you will be given a cash assistance of 1.5 lakh. And that is again a cashless treatment for the accident victim. And in the Rahavir, again, if you realize that you will be given a cash compensation, and if a person is repeatedly becoming a Rahavir, or if he's helping these victims, then that database will be created, and then they will be given a national award for this kind of support. So Rahavir is another important aspect wherein the government has come forward to bring in more and more people to get the victims to the hospital. See, if you don't have an existing pre-hospital system, then the time matters. If you have a gunshot injury, if you have lost your limb, if there is an amputation, if you have a severe head injury, if you are bleeding on the roads, time is of essence. And if somebody tries to make that person reach to the nearby facility, it is not the that has to be a best facility. It is the nearby facility wherein at least the first aid can be given. And after that first aid, the first aid means you are securing the airway, you are taking care of the breathing, you are taking care of the bleeding, and you are splinting the fractured part. So if you have taken care of all these ABCDs, which we call in our language, and then that stabilized person can be sent to a definitive care hospital. Similarly, this cashless treatment scheme has also come into picture, and this is a notification by the government on 16th May 2025. So there are still certain challenges to make it work lively in the hospitals. But yes, the process are going on. There's a committee members, and very you can see the empanelment is of very high people from the policymaker, and we'll have more discussion on this. So what I want to say is that government is doing its own. So it is now you people, we people, everybody has to come forward for this noble cause. Because remember, nobody is, I would say, not prone for accident. Everybody is vulnerable. Everybody is prone for accident. So today it can be anybody else, and tomorrow it can be you also. So with this selfish motto, we all have to try to save at least one person whom we come across. Yeah.
Thank you, Dr. Sagar. That was a extremely impactful and I hope motivating to everyone else line, and overall really insightful answer. So now that we've established that there are so many hesitations that people may face, including legal, I'd like to pass the time on to Mr. Gautam to ask what he feels on what legal or social barriers continue to deter bystanders or even victims from accessing immediate emergency care despite supportive policies. And could you share some lessons from the implementation of the Good Samaritan law in how advocacy can help bridge these gaps? Thank you.
Thank you, Asa, and thank you, Dr. Sushma. It was really a pleasure listening to your lived experience. As you rightly mentioned, Save Life Foundation has been trying to solve this challenge of road safety with institutions like yourselves for the last 17 years. And way back in 2012 was when we filed a petition before the Supreme Court of India asking for the institution of India's first ever Good Samaritan law. And after about half a decade of journey through the legislative and legal circles, finally the Supreme Court decreed in 2016 that everyone who comes forward to help a road crash victim will be protected, not just in the law, but from any kind of harassment they may face from police, hospital, or any other authority. Eventually, that whole legal framework got codified into the statute in 2019 when the Motor Vehicles Act saw its biggest ever safety related overhaul. and then the law was amended. Now, Section 134 in the Motor Vehicles Act, as well as Rules 168 and 169 of Central Motor Vehicle Rules, lay down these very specific safety provisions. Uh, it all starts with any of us witnessing uh, a crash victim, right? And I think if we were to be honest to ourselves, the first thought that will come to us is to, just evaluate what will happen to us if we go forward and help. The second thought perhaps would be to immediately go forward and help, not thinking about anything, but we'll be pulled back by certain, experiences, not just ours, but something that we've heard all over, that the police will detain you, the hospital will demand you to give your witness, the hospital will demand many other things like treatment costs and bound you down. All of those issues really affect our decision to whether help or not. So we sought to elevate it with the legal framework, but as Dr. Sagar really mentioned that having a framework is one piece, and like Asta you mentioned in your question, its enforcement and translation to the ground is really what matters. So it's been not a very long time, relatively, if you would see for other legal provisions being, enacted and then taken to the conclusive execution stage. We are still just 9 years from the Supreme Court judgment and 6 years from the Motor Vehicles Act amendment. There's significant improvement in terms of behavior of the authorities, but we really need to take this framework to the masses for the people to actually be aware and then be confident that they can come forward and help without jeopardizing any of their personal interests. So very briefly, I'll mention what the legal protections are. These are, protection from any kind of detention, any kind of compelling or compellment by any of the authorities, any kind of a forceful disclosure of any of your personal details. It's completely voluntarily. People can choose to be a witness and then divulge their details. But if somebody doesn't want to be a witness and only wants to help, even if they've taken the victim to the hospital, nothing can bound them down to, ascribe to any of the compulsions being made by the authorities. So this is overall the legal framework. These laws, these protections are guaranteed in the law, and any violation can have a legal any violation can have a legal recourse that can be taken. Now I understand that not everyone whose rights were to be violated could go to the court again and say that this was the law, this was the protection, but I was still harassed. There has to be a simpler mechanism. And now, with the schemes that Dr. Sagar really explained in very nice detail, the Rahavir scheme as well as the cashless treatment scheme are being rolled out by the government of India, which are now providing grievance redressal mechanisms at the district level for anyone to raise their grievance if any of the rights are violated. Of course, Save Life remains an organization that has in the past as well received a lot of these grievances. We have then worked with legal organizations across the country, pro bono organizations, to provide that kind of support to good Samaritans and help them overcome the harassment they may be facing. Uh, the last point, Asta, before we move on to the discussion, is that there's nothing really that now stops any of us to come forward and help. All that remains, in my view, is awareness and some kind of confidence building that both the government is trying to do with the schemes that I just mentioned, and all of us who learn about this have a responsibility towards. So if there are 100 people today listening to this, if we can go back to our lives and speak to three other people in our circle and ask them to again speak to three other people, we'll be able to start a chain where everybody becomes aware of these provisions. I've already told you it's section 134A of the Motor Vehicles Act, and it's rule 168 and 169 of Central Motor Vehicle Rules. You can always reach out to Save Life Foundation if or Crash Free India if any of these harassment types of harassment occurs with you. Really, it's now our duty to take this forward and get this implemented and basically join forces to make it a mass movement. Yeah. Asa, I hope I've covered all your questions, but very happy to answer them again.
I think that more than covered the question I had asked. And it's exactly what we at Crashfree India believe, which is awareness is more than half the battle, actually. Um, but great to know that there are so many legal provisions that protect and empower Good Samaritans. But since we're also talking about the cashless treatment scheme and the nitty-gritties of that, I'm sure everybody would love to know more about how equipped our current medical system is to actually enable this. So I'd like to circle back to Dr. Sagar and ask, in your view, how equipped are major trauma centers and empaneled hospitals currently to deliver cashless emergency care effectively? And what infrastructural, human resource, or other gaps remain? That's part one. And secondly, how do you think civic organizations such as CFI can help there to resolve some of these issues?
Uh, Asa, yeah, I can understand that it is easy to launch the policies, it is easy to launch the national programs by the government. But when it comes to implementation, India has a very varied structure of hospital. And many a times, I'm not undermining, but the private sector is not very keen to come forward in implementing these programs. Although everybody's law abided and everybody need to follow such policies, especially when it comes to accident victims. Regarding the hospital, yes, it was easy for our hospital to implement this scheme, whether it is Good Samaritan rewarding them, or whether it is upcoming cash free scheme or the Ravi scheme. But majority of the hospital, I would say that they are so overburdened by the medical legal formalities for these patients that to make them also implement this scheme in their hospital, they would need additional manpower for that, because they need a person who can keep the records of such people, their data, which has to be round the clock, because accident victims, they come in the middle of the night, they don't come in the, I would say, routine hours. So you need to have a round the clock system, and this cannot be done by the existing staff, which is the doctors or the nursing officers, technicians, or the other support staff. So you need a data entry operator kind of a person. And then whenever the financial thing is required, it is a very, becomes very tricky that the amount reaches to the right person. So for that, some kind of a framework or some kind of a resource uh, sanctioning is required. Even for launching the Ayushman scheme of the government, when it started, it is very difficult, to check the person's identity, whether they hold that Ayushman card or not. So here also, whether that money is going to the right person will become very difficult. So we need to link it with their identity, and there will be cropping off of the touts, who would like to come forward to help support these people to get their rewards, because 1.5 lakh is not a very small amount, and it is enough to take care of the initial, I would say, 72 hours of treatment cost of any victim, whether it in the government setup or in the private setup. Uh, but yes, additional manpower. So your second question was that how different NGOs or organizations like you can come forward. So maybe you can help them technically by developing some kind of, I would say, some app or some kind of a easy software wherein simply by entering the data, the amount is recognized and that amount straight away goes to their account or their whatever, I mean, say, simple mechanism. So that can be helped upon. So for the initial phase, I think these voluntary organizations need to come forward.
That's great to hear, and I think our tech team who's been attending would love to implement that suggestion and see if that's possible. But your answer really showcased just how complex the issue is, that even when we have good and supportive policies in place, there may be issues in actually delivering.
Yep.
And it's not necessarily one person's fault, it's just a very complex system. So I think you mentioned about private hospitals and their reluctance. So I think I'd really love to ask Mr. Gautam again, what mechanisms do you think are in place that could address private hospitals' reluctance to provide cashless emergency care? And how can policy ensure truly universal and upfront free treatment for trauma victims?
So, you know, the cashless treatment scheme is quite visionary, but it's just getting started. So, while it rolls out across the country, you have some very specific state schemes, like Dr. Sagar explained, the Delhi Farishte scheme, where the treatment is taken care of, and there is also a monetary reward. Then in Tamil Nadu, you have 48 hours of free treatment for anybody who's a crash victim. Across the country, there are other, different provisions in most of the government hospitals. Anywhere they might be, the treatment is free of cost and no questions asked. Uh, on a policy level, the cashless treatment scheme has come into fructification after a very long deliberation. It was piloted in the last 2.5 years across select states, and now it's finally notified. Rules are notified, guidelines are notified, and now it's being rolled out. So we can expect its operationalization by the end of this year if everything works out well. But that does not mean that there is a hindrance right now for a crash victim to be treated. In many of the private hospitals, they have their own systems where they would provide at least the stabilization treatment that Dr. Sagar was mentioning earlier, and then refer the patient for further treatment to government hospitals and government medical colleges. So really, there might not be a single scheme right now that's there in the country, but there are enough provisions for us to be able to take people to the medical facilities and provide the assistance. I lost the other part of your question, Asta, if you could come again.
Sure, I can repeat the entire question if that would help. I think it'll also help maybe other people contextualize, because these are complex matters we're dealing with. What mechanisms could address private hospitals' reluctance to provide cashless emergency care? And how can policy ensure truly universal and upfront free treatment for trauma victims as they're designed to do?
Yeah, I think end of the day, private medical care is tied to business, right? And it would be unfair to say that one should not do business unless you are profitable. You won't be in this service, at least for the private healthcare system, right? So there has to be a balance between moral responsibility and a feasibility of doing what is right. And as I mentioned that while in Delhi, Tamil Nadu, and several other states, there are standing schemes that reimburse private hospitals, and you would straight away get all the medical treatment necessary that that is required. in places where there's no such facility right now for medical private medical institutions, we have the cashless treatment scheme that is now being rolled out. Once it's rolled out and effective, I don't think there remains any other hindrance. The only problem being that it works on a reimbursement model. So going to a very technical aspect is that all the stakeholders that are involved. So in the cashless treatment scheme, it's the National Health Authority, it's the State Health Authority, it's the District Magistrate, and it's the Ministry of Road Transport. All of them have to play their role when it is required in that chain or in that lever, at the right time for it to be efficient. If there's any delay on any part, I think it will create a ripple effect where you'll have something on paper but not being translated to action on the ground. So it really is about the right implementation of this scheme, which many of us working with the Ministry of Road Transport have tried to ensure gets embedded in the scheme itself. There are many other provisions, in the scheme to safeguard the, expenses incurred by private institutions, even if the final claim is not approved, if the final verification is even not improved, they will be reimbursed for the time and treatment they provide to a crash victim. So the scheme really extends a very long arm to the private institutions to come forward and join this movement. Most of the Ayushman Bharat empaneled hospitals are taken up in this scheme already. The other non-empaneled hospitals are also extensively covered. So actually, there, nothing remains now except from the complete rollout of the scheme. And again, it's all about an efficient coordination between the systems. I would again use this platform to encourage at least the large hospital chains, to not just wait for any kind of government assistance to provide that essential treatment that is required. Many of these hospitals would have their extensive CSR budgets as well and CSR obligations. So it's critical that we introspect and ourselves decide that irrespective of there being a government reimbursement model or not, if any uh, crash victim comes to our facility, this is the minimum that we'll ensure gets provided. And for extensive treatment, of course, they can always be referred to government medical colleges if no other uh, you know uh, way around on the payment exists. But this really is for all of us to introspect and take forward.
So glad to know that there are so many available courses for action and recourse in implementing these schemes. Although coordination will be difficult, it seems that it is possible for this scheme to be implemented in a great way, hopefully. So I just wanted to take some time out to thank our wonderful speakers for their in-depth and insightful answers. As part of our effort to celebrate action, we've actually launched a dedicated platform, Real Heroes of the Road, a space where you can share your stories if you've helped someone in a crash or if someone helped you and changed the course of your life. And you can now submit your story on the Cast24 app. And once verified, your act will actually be featured publicly as part of India's growing Good Samaritan movement on our website. Our team would just like to show you what it looks like. So this is one example of our unsung heroes section. We actually run an entire blog dedicated to different aspects of road safety, and this is dedicated entirely to our Good Samaritans. As the website says, please be someone's reason to survive. And as our speakers have reiterated, we need to try and be selfish in the way that we expect that someone would try and help us out. in a moment of need, like we'd want to be helped. But yeah, with that, I'd like to open the floor now to our participants. Please feel free to drop any questions you have in the chat box. I'm sure you have many after hearing our speakers talk. So one of our participants asked, why is there so much apathy to implement law enforcement to avoid accidents and create regular road safety awareness in India? Would any of our speakers like to address that?
I think people are not aware of the Good Samaritan law. That is one thing which is keeping them away from helping them out. With this kind of awareness, actually, I would say that this awareness is most important. One is that follow the safety rules, and second is that Good Samaritan thing. That would definitely change the scenario. Yes, Gautam can also reply on that.
Yeah, I think it's one is definitely what Dr. Sagar mentioned, and uh, you know it's also about uh, the people responsible for implementation of this scheme to really follow it. So we really don't have a uniform uh, acceptance of this scheme amongst the system holders as well. So the police, the hospital, the kind of awareness and ownership that is required for this scheme or these legal protections is still wanting. So there's a lot that needs to be done. I think for the people in general, our basic instinct as humans and moreover as Indians is to come forward and help. But as I mentioned, there's so many other considerations that immediately come to our mind. So it really has to be a multi-pronged approach. Everyone responsible, not just the people, but the stakeholders have to take, extensive steps to create that kind of trust and an ecosystem where, our reflex action is to provide all possible help than to have any other consideration.
Thank you, Gautam and Dr. Sagar, for the really thoughtful answer to that question. If anybody has any other questions, please feel free to type in the chat. But until then, I'm going to rely on the questions that people have submitted in the registration form itself. So one other question I think Gautam would be able to answer very well is, do statistics or data about road accidents and hotspots available with the police inform road safety and policy making? For example, a road junction that is reported 20 crashes needs a traffic signal, but you know, in that case, who would take such a decision? Is it the police or civil or departmental authorities?
So the crash data, many of us would know, and others would be very happy to know that India has taken quite an extensive lead in instituting a national database for road crash not just statistics, but a lot more detailed granular data, which is called the EDAR system. Uh, in the EDAR system, the police is, mandated to immediately report uh, cases with geo coordinates. So you have a real-time identification of locations which are, becoming hotspots or can potentially become hotspots for these crashes, and it's actively now starting to guide a lot of our district and state authorities to take proactive and preventive measures. Uh, it's also helping policymakers to really evaluate the quantum of burden that exists for road crashes in their jurisdictions. What are the trends that are emerging? So really evidence-driven policy making is now getting to be the mainstay in India. The Save Life Foundation, in collaboration with the Ministry of Road Transport, is now expanding the zero fatality solutions model, where we are working actively in the 100 most critical districts as well as on 100 most fatal highways in the country to bring about data-driven and evidence-informed interventions uh, on critical locations and critical corridors. So you will see data play a very critical role um, moving to the future and then guide these policies. A lot of the nuances that exist now in the cashless treatment scheme have been guided by experiences of not just the pilot implementation, but also the crashed, database that we get through the EDAR system.
That's really great to know that we've started using that data in a very comprehensive manner and it's informing newer policies and initiatives that save life as well. Um, Actually, I'm glad to say that there's a question in the chat box actually to Dr. Sagar now. So, from Dr. Nirmal Kumar, why is India still not having a comprehensive trauma system? Would you?
Yeah. Yeah,
Yeah.
actually, you're very true that it is over last 10, 20 years only that trauma has actually been understood as a specialty, and people have realized that you need to have dedicated people who can work on trauma. It is like in the doctor community, it is very commonly said, अरे हमने तो बहुत trauma किया है, हम तो सभी trauma करते हैं. But there is a protocol approach to handling a trauma victim, wherein every minute count, every second counts. It is not like operating on a gallbladder or operating on a hernia or a abdomen. So here, I mean, you have to have a knowledge of the whole system. So to understand that in last 20 years there are dedicated trauma units being created in various hospitals, and NMC and as well as the National Board of Education has created DNB trauma seats. Trauma courses have been started. There is MCH in trauma and there is MS program in trauma. There are 6-year program. So in India, in almost 5 major hospitals, MCH trauma program is going on, and MS traumatology has come up. And government has made it mandated that you need to have trauma and emergency department in every hospital. So, what we are propagating through various, when we meet the policymakers, is that every hospital have an emergency department. You just need to create a unit. You don't need to build more and more of trauma centers. So, wherever, whatever is existing, you just strengthen that particular part so that there is a dedicated team who is available there 24/7 to take care of the victims. Because what is important in trauma is that patient cannot wait. So if we need to create a system where the doctors and nurses are waiting for the patients to arrive. So that kind of model need to be created wherein we can minimize the time gap between the arrival of the patient and the dedicated care, dedicated multi-specialty care which is being given to the patient. So yes, people are working on it. Ministry is working a lot on it, and I think we will see the results in coming years. One thing I want to add to what Mr. Gautam has said about the people who are working for it, I would like to say that Indian Road Safety Campaign has done a lot in last 10 to 15 years, and they have been going into every colleges and every places, and to make people aware, and students have been brought in because as doctors we were associated with them, and they made us visit even Bharat Parv, the pandals, the wherever there are large exhibitions. So there are various organizations which are already there, and each and every one. I mean, it is like sabhi ko aage aana padega. Yes.
Right. And Asa, I'd just like to add to the question that was answered by Dr. Sagar. Trauma care, for most of us, we understand it as, a well-equipped hospital, well-trained doctors. But essentially, the entire trauma system comprises, from the right at the moment where an crash occurs or an incident occurs till the time that a patient receives complete medical care at the hospital, as well as the rehabilitative stage. So it really is an extensive chain of events that need to be synchronized and followed in a continuous manner from each other, which we call as the chain of survival. It comprises of 3 stages. One is the at-scene care. Then there is the in-transit care where, a patient is being transported to a medical facility. And really the medical facility's role starts at the third stage, which is the at-facility care. So trauma care actually starts right from the moment an incident occurs. Unfortunately, the entire chain is not comprehensive in India. Not everywhere it's the same. Nationally, we don't have anything that's binding everything together under a framework. You have great institutions like AIIMS that are, really providing these model solutions, but for them to be replicated across, different geographies, different domains, what you really need is a national framework on national framework on trauma care, which provides standardized solutions for all these 3 stages of trauma care response. Uh, I'll just give you an example, right? The first step that is required to trigger the formal system of trauma care um, is a call to help, right? And that call to help right now is so confusing. People don't know whether they have to call the police, then it's 112 or 100, like many of us millennials and people before us knew the police helpline number to be. Or if it's the ambulance, if it's the ambulance, is it 108, is it 102, or is it 1033 that you see on national highways, or it's any other helpline, right? So essentially there's so much confusion, and now the government for the last few years has been really trying to bring together everything under the 112 framework, but we really have a long way to go for it to be, comprehensively in place. Similarly, many other aspects like paramedic standards, ambulance equipment, ambulance resources, uh, pre-hospital arrival notification systems, optimization of ambulance locations, standardization of referral protocols, so many other essential components that really form a key link in this chain of survival that are right now missing. And that's why, as I mentioned, institutions like AIIMS are spearheading this, but we need to replicate that model across the population of our country through a national framework for trauma care. So we really need now a national system for trauma care in the country.
Thank you so much, Gautam and Dr. Sagar, for that insightful answer to that very insightful question as well. I'd just like to wrap up as we're nearing the end of this session, and it's a Sunday evening, so I wouldn't like to keep anyone waiting. But I would just like to thank all our speakers for their valuable insights and for all of you for joining us today. Today's conversation really reminded us that road safety isn't just about the policies and systems. It isn't just about institutions, but it's about people, preparedness, and the power of timely action. As both Dr. Sagar and Gautam have mentioned time and time again, it's really up to us. And trauma care doesn't just start, when the patient is admitted to the hospital or when policies are put in place, but from the moment of the incident. So we really encourage everybody to take action, play their part. Road safety involves all of us. And that's why here at CFI, we understand that road safety is a multifaceted issue and we're doing our best, and we love to hear from you all on what can be done from every aspect, from every angle. So yeah, we'll be back soon with more conversations under the National Road Safety Webinar Series. And we're so happy that you attended our first ever session. Until then, stay aware, stay safe, and let's keep working towards a crash-free India. Thank you so much. If you have any more questions, please feel free to email us, ask us anything. We'll try do our best to get you those answers, either from our speakers or any of the other experts we're going to get for our future series, for our future webinars. Sorry, series already launched. But yeah, thank you so much.
Thank you so much. Thank you, Astha,
Thank you.
for this session. Thank you so much. Right.
Yeah, thank you, Astha, Dr. Sagar. Thank you so much.
Yeah, thank you, Gautam. Nice meeting you. Thank you so much.